Hello, Dr.
Hi.
Fisher.
Yeah, hi,
Hi, how
hi.
are you doing?
I'm good. I'm good, thanks. Yeah, are these things working? You can hear me okay?
I can hear you perfectly. Can you hear me
Okay.
okay?
Yeah, that's okay. Yeah, I can hear you.
Excellent. Well, thanks so much for meeting with me today. I know it's been really, really hard to squeeze in more Zoom appointments, and I'm sure you've been doing quite a few with your patients.
Yeah, they said something about that someone from the health department had to talk to me, and so I figured I better make time. I didn't know if like there's some kind of problem. I know everything's been kind of crazy lately, so I was worried that there was something wrong here or something.
Oh, absolutely not. This is meant to be just a conversation about an initiative that we're doing. And before I even get into that, I want to tell you a little bit about myself, and I want to hear a little bit
Okay.
more about how you're doing coping with the ways in which the pandemic is affecting your clinic. But I'm Suzanne Jones. I'm here from the Public Health Department, as you mentioned, and just here to talk a little bit more about how we can continue to keep our eye on patients during the opioid crisis and not let that fall to the back burner during COVID-19, and also find ways to connect with you that are easier than having me come in even after the pandemic is hopefully more well contained, and finding ways to fit into your schedule. So before I dive into our initiative, I'd love to just hear how you're doing. What's going on for you? How's your clinic running?
Yeah, it's been a tough go with the pandemic. We sort of for a while we were barely open. We were doing just emergency vaccinations, or a lot of days just not bringing anybody in. Now we're trying to bring people back, but we have to redesign all the space and put up plexiglass in front of our reception desk. And I
Yeah, it's a
really
lot.
worry, doing all these visits over the phone, am I able to really know what's going on? And some patients you just need to examine or be able to sit down with them and talk. So it's tough. I mean, I think we've done okay. I like to think we've kept connected with our patients, but it's been a very difficult period.
Yeah, it sounds like it. And I can't imagine the different kinds of stress and that you're under, and the flexibility that you have to do even above and beyond your typical flexibility. So thanks for being there for folks. I have a question about just conducting telemedicine visits more and more. Are you finding any perks to it? Any opportunities that you weren't expecting?
Some of my patients where just physically it's kind of hard for them to get to clinic, maybe they don't have a car and they have to take 3 different buses to get here,
Yeah.
or something like that. Or even, I mean, some of the young healthy patients like it because they mostly just want to check in and talk about how things are going. So there's some convenience, and that's a good thing for some patients. And like I say, some of the patients with transport issues. So as we're getting used to it, that there are days where it works okay.
Good.
But what it's like doing these calls. Sometimes they work, sometimes
That's
they
not the
don't.
same.
So yeah.
Yeah,
But there's some
absolutely.
convenience to it on the good days.
True. Yeah, there's things I like and don't love about it too, but I think if it's what we got to work with it. So it seems like since you've been doing these visits, e-visits with your patients, you probably have a pretty good sense of, all the different parts of these platforms that can be helpful just for keeping things, having lots of different visual pieces to look at. So right now, I have my chat box open in case you want to, text me a link or anything like that while we're chatting. We can always toggle sharing screens. And if as I'm going too slow, too fast, do you have any technical issues, feel free to just kind of wave your hand, jump right in, and we will figure those out. Do you have any preferences when doing online learning yourself, maybe when you're doing sort of online grand rounds or any Zoom calls at all, where it's easier for you to use certain features or you prefer certain features?
No, I don't think I'm that sophisticated. I mean, I appreciate you saying that about the chat box, and I'll definitely keep it where I can see it. And and I've sort of learned how to share screen, but otherwise I'm sure there's some whistles and bells I maybe don't use, but I can see this thing you have up here with like your headline and your orange picture. So that's that's working okay.
Yes, good. Well, that's where we'll start. So Yes, there is this new public health initiative from the state. We have some CDC funding to really look at getting naloxone into as many patient hands as possible, and really looking at primary care as the way to make that happen. So before I get too into it, I would imagine that everybody and their mother knows that this is still a crisis.
Mm-hmm.
Yeah. So,
yeah, I mean, we're not talking about it.
Oh, go ahead.
Oh, go ahead. I was going to say, we're not talking about it as much because of all the COVID stuff, but all those patients didn't go away. I mean, it's like all the stuff they're saying about, where are the heart attacks and where are the strokes? I mean, I do wonder the same thing about the overdoses. So yeah, it's still a big problem.
So talk to me a little bit about trends as, before the pandemic sort of, got into high gear, and maybe any patients you've seen since then. What are sort of some common through lines about what they're dealing with, and any challenges you might come up against in terms of supporting them?
Yeah, I mean, it's, I think at least as I understand it, a lot of the systems we've been trying to do for patients who maybe are on a chronic opioid, like medically from us, who we like to do urine tests intermittently or anything like that, or have them come in person, that maybe we can't, because maybe we just, some of the weeks we just weren't doing in-person visits. So you can't get a urine sample or make adjustments, or people who maybe got some pain meds, but you tried not to use too many pain meds because they would get like an injection from time to time. Well, maybe they can't, a lot of the procedural places just closed down. So it's tricky. I don't want to like increase people's doses and give them, make some other problem worse while this is going on. But it's been, so I certainly don't feel like put it this way. I couldn't tell you numbers, but it sure doesn't feel like it's getting better while all this is going on.
Absolutely. And that's something we're seeing nationwide. Specifically with your clinic, the things that you have seen, and even prior to the pandemic, would you, say that you're seeing, are you seeing patients with opioid use disorder often, and things like that?
Yeah, I mean, there's, I know there's been so much emphasis on how much we prescribe for patients, and that's, you always get a little nervous about that. And then, there definitely are folks, some who, started with medical, prescription pain meds and are using too much, and others who just, may have picked up, use of any of, the other opioids that are out there. I mean, heroin or the fentanyl stuff is scary, or whatever there is out there. So yeah, there is some, and, probably more than we realize from what everybody says.
Absolutely. And that's something that we're seeing actually happen more and more. So I'm going to pop through this slide since it's clear that you're up to snuff and then some. But I'd love to look at some state level data that really underscores that last point you made about, access beyond prescriptions. And if you look at this yellow line right here, we're really seeing that the synthetic opioids is really skyrocketing, whereas you're seeing, at least here in Massachusetts, prescription opioids really kind of staying somewhat steady, increasing a little bit here, but not at all as highly as this yellow line here. Does that seem to ring true with what you're seeing?
I mean, I think so. I think a lot of those patients with the synthetic opioids, we kind of don't see, the thing about the prescription opioids is we have that PDMP, and I've learned how to use that.
Oh, good.
Yeah. And, it's, so I can see what patients are getting, but it is like, yeah, it's like you and I were just talking about the, there's not a reliable way to know, unless people are like showing up in the ER or something with problems, what they might be getting out there for the synthetics. And so it's, it's definitely a little frightening. And then you hear the reports of, the fentanyl, I don't remember the derivative of fentanyl that's incredibly potent. That's, it makes you apprehensive, because I feel like I don't have a ton of tools to help patients with that.
Oh, well, then that's a perfect time for me to step in and talk about the tool that really needs to take center stage as much as possible. And, and that's naloxone, as you probably intuited from our little title. I'm wondering sort of what's your background with naloxone? What's your comfort level?
Oh, I mean, I'm familiar with it. Gosh, when I was a resident, we would, you'd always sort of end up, carrying some around in your pocket if, someone had, in post-op had gotten too much, too much pain meds during, right after a procedure or whatever. And so, yeah, you'd use it when you were training in the hospital. And I know there've been initiatives about, giving it to like first responders and, increasing
Absolutely.
awareness with EMTs and stuff. And, we've had some, I get some mailings and stuff about it in primary care, but I've never quite sort of found the right way to fit it in. I mean, it's always I've always sort of mentally seen as sort of an acute thing, the EMTs or even the,
Yep.
all the other first responders in the in-hospital settings.
Sure, absolutely. And that makes sense. I think, there's a real opportunity for all of us to consider primary care as like a trusted access point for patients who have not yet, dealt with overdose, and trying to catch them before that happens. I wanted to share with you, and maybe you've seen it already, this recent article that focuses on this non-randomized intervention study about, co-prescribing naloxone through primary care. Have you heard of this? It's from the Annals of Internal Medicine.
It doesn't ring a bell, but you sort of, there's so many papers, you end up sort of looking at the abstract, and I can never quite remember which one I saw where. So, but I mean, maybe this is where one of those handouts came from. Okay, good.
Yeah. So first big piece, looking at data for co-prescribing for primary care patients who were on long-term opioids for pain. And, this was based on the idea I just brought up a moment ago, that you're their trusted touch point. And so this is an opportunity for patients on those higher doses, and those who have been to the ER to have a protective preventive measure. I'd love to share some of the findings with you.
Yeah, no, go. I'm curious. Yeah.
These are the most impressive ones, at least to my mind.
Wow.
Results of the study show that 82% filled the prescription. And you often wonder, are they going to fill it? But in this instance, it was successful. No, go right ahead.
I'm impressed by that. I mean, I always sort of wonder, if it was a study, was someone really nagging them to do it? Because, lots of people.
Well, I can send you the link. I'll actually pop it. I'll pop the link into the chat box just so you have it.
Yeah, that would be good. I'd be curious, because 82% is good. I mean, I'm not sure 82% of my patients do anything I recommend. So that's pretty impressive.
Yeah, and with, given the pandemic, I don't think any of us are doing 82% of anything, but we're getting there. What was really great is they looked at attitudes and beliefs. There was some concern that self-stigma would prevent folks from getting these filled, and it actually turned out that 97% of patients said that they felt that all patients on prescription opioids should be offered naloxone. So that was a really cool finding. Yeah, and then afterwards, 63%, there was a 63% fewer opioid-related ER visits after 1 year, and that was compared to control group of folks who didn't receive anything. So this is really exciting stuff.
Yeah, that's a huge impact.
Yeah. Wow. So I'm sure we have this in there just in case, but I'm pretty sure, just based on talking to you for a few minutes, that you know how this all works. So
right.
Right?
I remember. Yeah. No, and I remember, okay. I see the thing you have about, the 30 and 90, because I remember, from back in residency, you have to give, and then you have to watch them, because then the naloxone wears off and you have to dose it again. Right. But again, that was all when it's been a long time since I worked in the hospital.
Yeah. Well, the good news is there's a lot of, refresher videos out there and things like that, but it sounds like you're on top of it. And kind of getting back to what our campaign is about and where we're trying to help primary care is to really look at, if there's an increased risk, if patients are at higher risk, then prescribing of naloxone needs to go up. And there's some new, there's a new statement as of just a couple of weeks ago from the AMA that I'd love to share with you. It's really encouraging these frontline providers just like you to look at any high risk patient as someone who should receive a naloxone co-prescription. And then the other piece of that statement from the head of their opioid task force, they're really starting to focus on harm reduction strategies, which is exciting because AMA is typically a bit more conservative. So looking at harm reduction is something that we really hope they can impress upon folks to see as important. So I'll pause there and just stop and see, how is this feeling so far? Does this feel like, you know, it's kind of going in the right direction, or what are your concerns about potentially implementing this?
Yeah, I mean, I'm definitely sympathetic to it. I mean, you know, you lay out the reasons, that study's compelling. You're right. You know, I know it works. I mean, I hear what they're saying here, the harm reduction. I always wonder about that balance. Like, are we, you know, we talk about harm reduction, but then are we kind of, you know, are we kind of saying, you know, like, as opposed to focusing on to patients on really like, don't take this poisonous substance that is trying to kill you. You know, instead we're sort of, you know, giving them, and like, it's just why I'm on the fence. Like, I get, yeah, like you know, I get why it's a good idea, because in the moment, obviously, if there's a patient there who's taken too much of an opioid, you want to give them naloxone, because then, so I get it, but I guess it's where the primary care part I struggle with is like, you know, if I'm just sitting there with them and they're on opioids, maybe even they tell me they're using something illicitly, I get the reasons for harm reduction, but I worry, like, you know, if my reaction is, okay, that's great, and here's, you know, here's the naloxone, am I being as strong as I could be to try to give a message that, you know, that using these high dose opioids is a bad thing for your health?
Okay, let me see if I'm catching what you're saying. So it sounds like you're saying, is this, do I need to kind of have a stronger conversation about how dangerous this is, and is prescribing naloxone kind of giving them a safety net that might encourage them to
I don't want to sort of
more?
I sort of don't want to come across as giving, you know, I mean, not permission, I mean, patients make their own, but, you know, giving sort of permission in quotes to you know, to do something that's so risky. So I don't know, I feel like it's kind of a struggle.
Okay, that makes total sense. And you may notice I'm just kind of tracking our conversation in the chat box just so I can make sure I don't miss anything. And if you see what I'm typing and it's like, you know, you think of something else to add, or maybe I didn't get something quite right, don't hesitate. But this concern, I'd love to dive into it. And I think one thing to consider with the harm reduction approach is it's really not looking for perfection, it's looking for better, right? And so on this next slide, I've got a couple different, pardon me, I just skipped one, here we go. This slide is primarily on cost effectiveness, but if you look down here at this benefit, 164 prescriptions is one prevented death. And we could look at that as, well, you know, that's a lot of prescribing for one person's life, but you also can't put a, you know, a number or, you know, a price on saving a life. And even if you have these conversations, prescribe naloxone and even save one life, I would say it's worth it. And I would also say there are other ways we can access having difficult and challenging but honest conversations with your patients that dive a little bit more into the risks, because you're not just handing out a naloxone prescription without context. You will be discussing the risks that they, you know, are up against. Does that kind of answer your question a little bit? And I can show you a little bit more.
Yeah, I think that last part really does kind of make sense, that if we're saying, you know, this is naloxone, but maybe even, I guess it's still that balance. Like, you want to say that naloxone's good, but you also want to say, like, big picture, I'd much rather they just didn't even need it in the first place.
Right.
But yeah, you could sort of like having that balance, maybe that might be a little bit of a better way to deliver the message.
I hear what you're saying though. And really what we're looking at is, it's frustrating. And at least this is the energy I'm you know, sort of the message I'm getting from you is, it's frustrating to not be able to do more and to feel like it's such a huge problem. And the scope of the problem really is massive. But I think any little thing we can do, and the more that we take this approach consistently and systematically, the more of an impact we're going to have. And so I think just focusing on small wins to start, and the more that folks like yourself do this, if we get 10, 20, 30 primary care providers to do this, that's a ripple effect that's bigger than just one person. So it's also a campaign that's larger too. So don't feel like it's all on you. I'm aware that we only have a little bit more time left. I know that you said you had 25 minutes and we're at about 20. So I want to respect that time. I saw that in our calendar invite, because I know you probably want to break before you pick
you're right. I mean, this is interesting, but I do, you know, well,
Yeah.
I'll probably end up seeing some patients on Zoom like this, but I do have to go do it soon.
Yeah. Well, my hope is when we're done, you may be able to keep an eye out for folks who this might impact positively. So what we'd love all primary care providers in the state to do is just consider offering any patients who are on long-term opioids a naloxone prescription. And of course, anybody else who might indicate that they're at risk of either, having an overdose or witnessing one. So let's say you know somebody who's not on long-term opioids, but they discuss that they're living with a grandparent who might be. If that sounds like a risk factor to you, if you start to kind of ask them about their lifestyle and their health, that's a time when, maybe co-prescribing could work. And then we have a lot of really great patient education materials. And I think this would be really key for the concerns you brought up before of, how do I kind of have those deeper conversations and not feel like I'm just sort of stepping out of the way and not addressing the issue. And the VA has a ton of great video, patient-facing videos, not just on how to use naloxone, both the nasal spray and the injection, but also what folks who have survived overdoses and have used naloxone say about it. I don't know if this might be of interest to you, if you'd be willing to share this with any of your patients, but I have the link and I can just pop it over to you and also send it via email.
Yeah, I definitely have to look at it before I give it to patients, but the VA is usually good. And I know that unfortunately veterans, have a lot of these issues. So, I always sort of, when I see studies on this from the VA, I kind of figure they know what they're doing. But yeah, I'll take a look at it and see if it's something I can show to patients.
Sure. Quick question for you based on something you brought up. So when you were mentioning feeling like you wanted to kind of have some of these deeper conversations and not just sort of hand off the naloxone and step out of the way, do you feel like you said you were looking for tools, and I'm wondering, do you have tools around just the kinds of things to say that could kind of help that kind of conversation be a little more fluid and comfortable for you? I guess I should say, I think a better question. Let me reframe.
Oh yeah, sure.
Yeah, maybe a better question is, how have conversations with patients gone before about opioid use?
Yeah, it's funny. It goes, goes up and down. I mean, I've had some patients who, who'd been on opioids, but who sort of start to see what's in the news and actually come motivated to reduce their dose or get off, and some who just don't see it. They've just gotten, in whatever way it's become, the only way they know to cope with their pain, which isn't ideal. So that's definitely a real challenge as we try to think about what to do. And it is hard. I mean, these are sort of hard things to bring up. If I'm giving them naloxone, so I'm kind of saying, am I saying, I think you have a problem? Like in some ways, I don't want to sort of bless it or whatever, like we talked about, but I also don't want to come across as saying like, yeah, I think you have a problem with opioids and somehow alienate the patient. So it is tricky to figure out just how to frame it.
Absolutely. So we do have a bunch of resources that kind of run the gamut of different scripting tools and ways to talk about it. And, there are some screening tools that help you identify and start those conversations. I think one thing is to just be fact-based and really look at, here's some great examples that we have. Just saying something like, I know that you're on X dose of opioids. I just want you to know that opioids can slow or even stop your breathing. I mean, that right there speaks for itself. And it's not stigmatizing versus saying, I think you have a problem. You're talking about the medicine itself.
Right. That's a good point. That's a good point.
Yeah. And I think folks could feel stigmatized about being prescribed naloxone, but this second bullet here about it being just like an epinephrine pen for someone with an allergy really normalizes it and just makes it clear that it's an antidote. So these are the kinds of, conversation starters that can really make patients feel comfortable. Would you be interested in me sending over some of these sort of scripting starting points?
I'll take a look at them. I mean, I'd certainly think about, and I like the way you said it, if you frame it about, it's a concern about the pill, because for whatever reason, people are concerned about, there's been a lot of time being concerned about the side effects of a lot of meds for like their cholesterol and diabetes that I know really help
Sure.
them and aren't nearly as dangerous as opioids. So yeah, maybe if it's more
Yeah.
about the
Yeah.
medicine could have a side effect, maybe that'll
Yes.
connect a little better.
Absolutely. Absolutely. I do have a testimonial here. I can send it to you later for a quick peek because we're running out of time, but this is a quick one about, how patients don't even realize they're at risk, and even just starting that conversation can sort of open their minds up to it. So I want to wrap up and respect your time. I'm wondering how you would feel about the potential of, looking at that scripting tool and considering, following up in a couple weeks to discuss whether you feel you'd be ready to try prescribing naloxone as a co-prescription with the next 3 patients that you would see who would be receiving an opioid prescription. Do you think we could do that as a 2-step process and just start with you reviewing some of these materials and I could follow back up?
Yeah, I mean, if I see you've been taking these notes and they look pretty helpful. I'm not as good a multitasker, so I've sort of seen some of them, but I'll take a look at those and I'll definitely think about it. I mean, the things you say make sense, they're always, with all this Zoom stuff and everything, you're always running out of time. But, I'll take a look if I can make it fit with everything else I have to do in the visit. I'm not opposed to this stuff. I mean, it sounds, it sounds very sensible.
It does, but I also do want to respect that you're saying that it's a crazy time. So let's just stop here and quit while we're ahead a little bit. Are there any other ways I can support you besides following up, sending you that study, sending you the VA link to the video, and then sending over some scripting tools for you to just take a peek at and then following up in a couple weeks? Are there any other tools you can think of that you'd love to have? And you can think about it. Doesn't have to be now that you decide.
Yeah. So the one that pops to mind would just be something, and if you're coming back in a couple of weeks or you're calling me again, whatever this thing is, calling me on this thing in a couple of weeks, is just something about, are there any issues about it being covered or co-pays, or like, do they waive the co-pays or something? Because, I have a bunch of my patients who, I know, and they're always embarrassed to say it, but, struggle with medication costs. And so I want to be, I don't want to put someone in a bad position. So if there's anything, I mean, I don't know if this is one where their copays or like, something special I can do to get it covered for them, but that would be useful to know.
Absolutely. I can tell you that Mass Health does cover quite a bit for folks who are uninsured otherwise, and the costs are fairly low, and sometimes it can be free. So let me get, I have a 1-pager I can pop over to you on that.
Okay.
So I have a little note here. I'm going to follow up in terms of sending that over to you along with the other resources. What time frame would work best for you? Would you say 2 weeks? Did that sound about right? Or would you prefer it to be longer?
We can do 2 weeks. I'll probably have to be a little, quicker next time. I mean, I think, we ran a little long today, but that's okay. It's been interesting. But now that I know who you are and what it's about, maybe we can zip through these things in a couple of weeks and just see where we're at.
Sure. Yeah, we laid a lot of groundwork today. Would you prefer me to email you in advance of, setting up, or just give you a call?
Why don't you do that? Just email me, because then you can send me a link for this thing. And that seems to work. Like for this, I just clicked on the link that showed up in my schedule, and that seemed to work okay.
Awesome. Okay. Well, thanks so much for taking the time. And you're right on that, spending some time laying the groundwork now means we can dive right in next time. So I'll follow up with you in 2 weeks, and thanks so much for your time.
All right. Well, thank you I guess you didn't come by, but thank you for virtually coming by.
You're welcome. Take care.
All right. Bye-bye.